Thank you very much, Dr. Dinesh. At the outset, I would like to thank Dr. Garg for inviting me to speak here. In the interest of time, I think we're running short. I'll show the pictures and the angiograms. So my topic is FFA in posterior uveitis. So basically, inflammation is a very common denominator in formation of cystoid macular edema. Before I go on to the conditions, I'll first show a picture of a cystoid macular edema. So there are a collection of the dye here in the macular region in the form of patloid spaces, and the disc is also hyperfluorescent in many of the inflammatory conditions as well as in surgical edema also. And OCT of the same condition here. Ever since the advent of the OCT, FF is less and less required, but if necessary, we can do that. Another picture of cystoid macular edema, similar patloid appearance. So then, first condition is VKH syndrome, Vogt-Koyanagi-Harada syndrome. It's a bilateral granulomatous uveitis with exudative detachment. There are multi-system involvements also. There's a hyperemic disc and exudative RD in this picture. And on angiogram, and another one here, there are multiple hypofluorescent spots here in the early AV phase. As the angiogram progresses, they become hyperfluorescent. Then there are pinpoint leakages at the level of the RPE. And then there's a collection of the dye in the exudative detachment area, pooling of the dye. Sympathetic ophthalmia is another similar condition, but the history is different. There's a history of injury. It's also called sympathetic uveitis or sympathetic ophthalmitis. It's a rare or uncommon bilateral granulomatous uveitis. It can occur few days to several years after the injury. Almost a similar picture on FFA, just like VKH syndrome, and even on histopathological examination also. This is the injured eye. These are the clinical pictures with multiple exudative detachments, pinpoint leaks here in both eyes. This is a sign of the injury. Next is a Behcet disease. It's a chronic multi-system disorder which is found along the Silk Route, right from the Mediterranean region up to the China and Japan. Characteristic history is a recurrent oral ulceration, genital ulcers, skin disorders like erythema nodosum, and panuveitis. There's a hypopion, fleeting hypopion in this condition. Hyperemic disc, capillary leakage. It's a very peculiar of Behcet disease, leakage at the capillary level. And in the late stages, there's the optic atrophy, vascular sclerosis, and retinal infarcts and fibrosis. Ocular tuberculosis, it's a very common form of extrapulmonary tuberculosis. It can present as serpiginous choroiditis or choroidal tubercles. There can be hematogenous spread or direct spread or hypersensitivity to the tubercle bacilli. So there is a lesion here and the posterior pole. Central part of the lesion is healed, where the peripheral part is active. So healed lesion gives a hyperfluorescent area in the center, and peripheral part gives a hypofluorescent area. So that is a choroidal tubercle in the left eye of the patient, abutting on the fovea. As the angiogram progresses, it becomes hyperfluorescent. And later on, there is a collection of the pooling of the dye in the area of the detachment, exudative detachment. So next is the sarcoidosis. This is also, can present in an umpteen number of ways. It can cause vasculitis, it can cause granuloma, it can cause new vessels on the disc and elsewhere. And here it is shown as a granuloma, which is becoming hyperfluorescent in the angiogram. Serpiginous choroiditis is a bilateral uncommon disease of unknown etiology, finger-like projections from the disc in a geographic pattern. There are various stages of the lesion. Visual acuity is good if the fovea is not involved. There can be early hypofluorescence and late hyperfluorescence within the level of within the lesion. Active lesions can be hyperfluorescent, which can be confirmed on the angiogram, and CNV can get formed, which will give its own peculiar classic CNV appearance. There are two varieties of the serpiginous choroiditis. One is a classic variety, which was shown in the previous picture, and this is a macular variant of the serpiginous choroiditis. Location is in the macula. This is more devastating for the vision. Otherwise, the clinical appearance is the same.
Please conclude, Dr. Vic. Please.
Okay. So these are the APM-PP fundus angiograms, initially hypofluorescent, becoming hyperfluorescent. Birdshot retinochoroidopathy, clinical picture, multiple spots seen on the angiogram also. Syphilis also can have various presentations, but the commonest is vasculitis as seen in this picture, and the leopard skin appearance, very characteristic. Optic atrophy and vasculitis and vitreous in syphilis. It's become more common in the era of the HIV. Multifocal choroiditis, right eye is less involved, left eye has a bridging fibrosis, multiple lesions, and there is a napkin ring around the optic nerve in the upper right-handed picture. On angiography, there are hyperfluorescent lesions. The new lesions are hyperfluorescent, and the old lesions are staining like a scar. Thank you. Last condition is multiple evanescent white dot syndromes. It can be unilateral. The spots will come and go. There can be very characteristic fibrous granularity, and angiogram will show early hypofluorescence and late hyperfluorescence. Thank you for your attention.